diverticulitis is the topic, and diverticulitis is basically inflammation of the diverticuli. And I'll draw a very quick diagram of the colon. And this is the ascending, transverse, descending, and then the sigmoid colon, which is this part right here. And what happens is, over time, the colon, in particular the sigmoid colon, the colon wall becomes weak and can develop these outpouchings, which I will draw as an exaggerated. They're usually not this big. They're very tiny actually, but I'm drawing it large for the sake of the diagram. And the sigmoid colon tends to have increased pressure, so that's why it's usually involved, and that's why where most of the diverticuli happen. So this is essentially, I'll draw it up here, our diverticuli. This one right here. Now what happens over time is you can get this fecalith deposit inside, and this is known as fecalith, and undigested food particles, things like that. And what that can do is it can lead to inflammation, and it can also lead to a perforation. So diverticulitis is essentially this process right here, the inflammation of a diverticuli. Most commonly in the elderly population, most commonly in the sigmoid colon, which on physical exam would be left lower quadrant. Very important to remember that. So let's get started. Basically, a little bit of tidbits about diverticulitis. Elderly population, most commonly sigmoid colon, and left lower quadrant. These are some of the very key aspects of the clinical vignettes that you will see. So let's start with the symptoms. Basically, you will have a patient that is elderly that presents with pain in the left lower quadrant, LLQ, left lower quadrant. Very important to remember, because right lower quadrant is a different presentation, because right lower quadrant is appendicitis, and also appendicitis usually occurs in the younger population. You can also have fever, and in more severe cases you can have abdominal signs such as rebound and guarding. Diagnosis: if you have an elderly patient who already has established diverticuli, and this patient is presenting with these symptoms, then you're definitely going to think of diverticulitis. And there's some basic blood tests, like a white blood cell count, which would be increased if there is indeed a inflammation, perforation, things like that. But the gold standard of diagnosis of diverticulitis is an abdominal CT. And this is definitely what you need to do. Colonoscopy is actually not indicated in the acute setting because it can cause a perforation. Now, after everything's resolved, then a colonoscopy can be done after resolution of an acute infection, but it's not done as a way to diagnose it. Treatment. Treatment involves keeping the patient NPO, nothing orally given, IV antibiotics, and although they don't always ask which antibiotics, it's probably not a bad idea to remember that it's a combination of two, usually. Most popular combination is these two, metronidazole and ceftazidime, given IV, of course. And yeah, that's essentially the hallmark of the treatment of diverticulitis. And sometimes, if it is very severe, there's some significant perforation involved, and the case is very severe, then surgical treatment is necessary. So let's take a look at some vignettes and see what this looks like as a patient presentation. A 70-year-old man presents to the emergency department with complaints of abdominal pain. Describes the pain as crampy and primarily in his left lower quadrant. He has had minimal nausea, but complaints of constipation. His past medical history is significant for hypertension, hyperlipidemia, gout, and diverticulosis. Medications include atenolol, simvastatin. He's allergic to penicillin. Temperature is 100.4. Blood pressure is 140. Pulse is 100. Respirations are 20. Physical exam is significant for tenderness to palpation at the left lower quadrant without rebound or guarding. His rectal exam is GOAC negative. Heart and lungs are unremarkable. Which of the following most likely diagnosis? Well, this patient essentially has everything, pretty much spelling out diverticulitis. He already has diverticulosis, but in this case he's presenting with fever and an acute abdominal pain in the left lower quadrant, and he's an elderly gentleman. So, without a doubt, diverticulitis. Classic presentation. It's interesting that they put appendicitis. That would be right lower quadrant pain. We just wanted to point that out. Next one. 70-year-old man presents with severe acute abdominal pain. Physical exam reveals tenderness and guarding, with guarding localized to the left lower quadrant. Complete blood count with differential shows a white count of 18,000, which is high, with increased neutrophil band forms. Paracentesis demonstrates mixed flora bacteria with many neutrophils in the peritoneal fluid. Which of the following is most probable source of infection? Basically what's happened here is you've got this diverticuli that's been obstructed by fecalith, and that's become inflamed and has perforated. So there's been a perf here, and that's causing this presentation, which includes pain in the left lower quadrant, increased white blood cell count, and this is also a classic presentation of diverticulitis, and the source of infection is a colonic diverticulum. These outpouchings are called diverticuli. And finally, a 55-year-old is brought to the emergency department by her daughter with left lower quadrant pain, fever, anorexia, chills for the past 24 hours. Temperature is 101. Respirations are 18. She is awake and alert, although she appears uncomfortable. Examination shows hypoactive bowel sounds and soft abdomen with mild voluntary guarding, especially in the left lower quadrant. Digital rectal exam is significant for heme-positive stool. EKG shows sinus tach at 110 beats per minute. No ST segment changes when compared with old EKGs. Chest X-ray shows no acute disease. Abdominal X-ray reveals no air under the diaphragm, no ileus. CBC, biochemical profile, cardiac enzymes, amylase, lipase are drawn, but results are not yet available. Most appropriate initial management of this patient is. Well, let's go through these one at a time. IV antibiotics, NPO diet, and abdominal CT. Well, this is the management for diverticulitis, which at this point seems like the right answer, but let's just keep going. Discharge to home on a clear liquid diet and PO antibiotics, probably not. The reason is because that would probably be okay if it was mild case, but she's got fever and she's got obviously severe enough pain to have been brought to the emergency department, so I probably am not going to go with B. C, immediately refer to gastroenterologist for colonoscopy. Again, I think I previously mentioned that colonoscopy is not good to do in an acute attack of diverticulitis because you can have a risk of perforation. So probably not a good idea at this time. Maybe after everything is resolved, but at this time, no. Next one, prepare the patient for immediate surgical exploration. We need to actually do the abdominal CT first to figure out what's going on before you just rush them off to surgery. You need to actually have a confirmed perforation and, established diagnosis before this can be done. So not that. And last one, send patient for urgent cardiac catheterization. That's just irrelevant because they're talking about cardiac, and there's nothing here. See, there's no ST segment changes, so it's not really an acute cardiac event. So by process of elimination, it's A, and A definitely is the right answer because this IV antibiotics, NPO diet, and abdominal CT is definitely the management of acute diverticulitis.